Good afternoon, everyone. Thank you for joining us today. I'm just going to give it a few seconds for folks to join. All right. For interest of our time, I'm going to just start with some housekeeping and accessibility notes today. Welcome, everyone, to the Medicaid 2.0 webinar. My name is Mary Kate Wells. I use she, her pronouns. A white woman with a bright pink shirt on. I am the program director at NICL, the National Council on Independent Living. And today's webinar is a joint webinar with NICL and NACDD, or National Association of Councils with Disabilities. And we're so excited to bring these two networks together today. Today we have captioning available on this webinar. You can click show subtitles in your Zoom menu to turn them on. We also have captioning running on an external page that we will put in the chat. ASL is also available today and should always be present on your screen. If you cannot see the interpreters, please let us know in the chat. If you're joining by a mobile device, due to some Zoom updates, you may not be able to see both the interpreters, sign language interpreters in the screen. But if you adjust your view, you should be able to swipe on your screen and see the ASL interpreters. We also have Spanish interpreters today, which can be accessed at the bottom of your Zoom bar, and you can select which language you would like to hear the webinar in. Public chat is turned off, but you are able to message the host and panel. We ask that you use the chat to ask any technical questions. If you have questions for our panelists, please use the Q&A box. There is a button at the bottom of your screen as well. If that is not accessible to you, you can also email me, mary-kate@ncil.org, if that is a more accessible option. We will be answering questions at the end of the webinar. So without further ado, I'm going to hand it off to Erin to get us started.
Thank you so much, Mary Kate. My name is Erin Prangley, and I work in Washington, D.C. for the State Councils on Developmental Disabilities. Hopefully you're all familiar with them, but there is a state council in your state and territory. So to have a chance, look them up. They're doing great work. Welcome to Medicaid 2.0, New Opportunities for State Advocacy. Act now. I want you all to take a moment to picture the government and CMS as a big house with lots of doors and locks. All of the important decisions in our lives are made inside of this house, but many are behind closed, locked doors. 35 years ago, there was a room where people with disabilities were not allowed to go. And in that room, people without disabilities decided that people with disabilities were better off living in institutions, away from their friends and families, without access to careers or recreation, isolated and at risk for abuse and neglect. Lucky for us, Lois Curtis and Elaine Wilson kicked down the door to that room and gave people with disabilities the key to that room in the Supreme Court decision called Olmstead. That decision gave people with disabilities the right to receive supports and services in their communities rather than institutions. But just because Lois and Elaine got us the key to that room doesn't mean our work stopped. In a lot of ways, our work has only just begun because many people still don't get the services they need to live life on their own and in the communities. You see, the prior tenants in that locked decision-making room were people who made money off of institutions, people who didn't believe that people with disabilities could live self-determined lives, And sadly, some are still in there making decisions in our state houses and federal government that are not in the best interest of people with disabilities who want access to live in the communities. Sure, we have that key that Lois and Elaine gave us, and we may even be in the room, but now we need to get to work, kicking those folks out that would keep us in institutions and making changes to our government so it works for us. We've seen so much progress in the last 4 years. In fact, more progress that many of us have seen in over a decade. This administration under President Biden and the leadership of Allison Barkoff and Nancy Thaler, who you'll hear from later at ACL, have made new rules so that people with disabilities can design the services and supports that they need in their states and in their communities, but only if people with disabilities are aware of these new rules and organize to take advantage of them and share the information with others. Today, your call to action is to take the information that you learn here and organize in your state to make Medicaid and HCBS services, home and community-based services, work for you. You will hear from Nancy Thaler from the Administration for Community Living about important policy decisions that will take place in your state starting this year and continuing for the next several years. You'll also learn how to be a part of a new Medicaid Beneficiary Advisory Committee to make community living a reality for people who are stuck on long wait lists or still in institutions. Then you'll hear from experts from Arkansas who will share how they're organizing to make sure that people with disabilities are at the center of these decision-making to improve these services. And finally, your call to action. At the conclusion of the webinar, we will share contact information to all the participants who opted in so that you can connect with each other and organize at the state level. It's your turn to take that key given to you by Elaine and Lois. Open that door, make all the renovations you need to make home and community-based services available to you and all of our friends. And now it's my pleasure to introduce Jessica Puesta, my colleague and friend, who is the Director of Advocacy and Public Policy at the National Council on Independent Living. Jessica.
Hi, everyone. Thank you so much, Erin. I couldn't have said it better myself. Hi, my name is Jessica Puesta, and I am the Director of Advocacy and Public Policy at the National Council on Independent Living, and I have the privilege today of introducing our first speaker. So our first speaker will be Nancy Thaler, who is the Senior Policy Advisor for the Administration on Community Living for the U.S. Department of Health and Human Services. Nancy will be providing an overview of the historic access rule and what the timeline is for states' implementation of these new rules and why advocates should focus on the creation of beneficiary advisory councils and Medicaid advisory councils. So I'm really excited for this presentation, and without further ado, I'm going to turn it over to Nancy.
Thank you so much. And I think somebody else is going to forward my PowerPoint. Great. So I'm Nancy Thaler. My title is Senior Policy Advisor. I work for Allison Barkoff at the Administration of Community Living, one of those rooms in that big house called HHS. I am a slight woman with very short blonde cropped hair and eyeglasses and gold earrings today. I'm not going to talk about the whole rule. The whole rule is really very comprehensive and very long. And secondly, I'm very cautious about talking about the rule, that is, we in ACL are, because the rule is CMS's rule. And when you read the publication and you read the preamble, you can see that there's lots of room for interpretation. So what CMS intends to do and what they are in the midst of doing is writing what they call sub-regulatory guidance. They're creating toolkits. And so we don't want to jump the gun. So I don't want to go what's beyond the specific written rule. The last thing before I start to talk about it is I think that your request for me to talk was because of the stakeholder participation component of it, but it's bigger than just the MAC and the BAC, and those two things. So I went through the rule and pulled out things that I think as people who want to be engaged with states and need to be engaged with states, components that benefit you. They are benefits to stakeholders as well as for stakeholder engagement. So next slide. This slide is a timeline that shows when specific components of the rule must be put into effect. And the timeline goes from 2026 all the way up to 2029. And in each of those years, certain things have to happen. So for instance, by 2026, a grievance procedure has to be up in place in a state. And that might seem like a long time away, but in government time, it's not at all, because the states have to develop policies and procedures. They might have to have legislation. They've got to create technology systems. So there's a lot of work to getting up a grievance system up and running. And it's something you might want to engage in with the states. You might want to put yourself forward as being a resource for developing that grievance procedure. What are you going to define as grievances? Who's going to get them? What's the vehicle for reporting them? I'm not going to go through the whole timeline, just a couple things. 2027 is the next big year, and that's all I'm going to talk about. That's the year where a state's incident management system, meaning the reporting process, not the technology yet, has to be in place. Critical incident reporting and performance levels are in place, reporting on person-centered planning, reporting on waiting lists, reporting on whether people have access to service, the website transparency. A lot of this rule is really slated to be the states must comply with it by 2027. And again, seems like a long time away, but it takes time not only to do all the policy work and the legislative work and the regulation publication work, but also to engage stakeholders in all of those things. So I have seen other versions of the timeline. CMS will be putting them out more in the future, but this is nevertheless one that I thought would be helpful to all of you. Next slide. So there are only a couple slides here about what's in the rule and what dates things are effective and what you might be interested in. So the first thing is not about HCBS services, it's about all of Medicaid and CHIP programs. And it establishes national standards for certain appoint wait times. I'm not going to go into the specifics. The rule talks about which ones and where, but this is, you know, I'm sure I'm not the only person who has wasted hours sitting in appointment rooms with nothing to do, waiting to go in to see the doctor. Well, or I have waited 6 months to get an appointment. So this rule is an attempt to fix some limitations and required timeframes for how long you have to wait for services. So that's something you want to be alert to in the future. The next two are, I think, pretty interesting requirements. One is that states conduct secret shopper surveys of their Medicaid and CHIP programs. So this is like the general health care program and behavioral health and dental, et cetera. So secret shopper surveys are hiring people to go out or to participate as though they were a beneficiary to attempt to use the system and to get information about how it works and doesn't work. And who better to be a secret shopper than people who are actually familiar with the service system? So you might want to ask your state, how are you going to do that? Are you going to engage us in developing your secret shopper surveys? And how are we going to know what the results were? The second is for every managed care plan, it requires enrollee experience, beneficiary experience survey. That is a survey that goes out to ask about your experience. And I want to say, this is like voting. A lot of people don't want to do it. They don't want to fill out experience surveys. They don't want to do feedback surveys. And I certainly know when I go to the hairdresser or the doctors and I get an email that says, we want to hear from you. It's like, oh, yeah. They want to hear from you. And if we don't respond to surveys, they have every right to think that everything's okay. So, educating all of the stakeholders in your groups about the fact that there are these experience surveys and it's important to respond to them. And also having interaction with the Medicaid agency to make sure those experience surveys are accessible, that you can participate in them. The next thing on my list is that the rule creates a framework for what's called a quality rating system, so that managed care plans in almost every state now, all of the physical health is in managed care, and even behavioral health is in managed care, that there is a one-stop shop for people to be able to compare your managed care plans. So in effect, what this says is report cards for the managed care plans. So when it's time for you to choose which one, you have some information about them that compares them to each other. So, this is a benefit, but only if the person knows it exists and they can review it before they choose their managed care plan. So here's another one. And this is pretty revolutionary. And I thought I would never, ever see this in print in a federal rule. But the federal government's very concerned, as is everybody, about the direct workforce crisis, not finding enough workers. And one of the issues we know is payment. So there are a lot of rules in the regs about the states having to report to the federal government about what percentage of their fee goes to paying direct care workers. In the future, there's going to be a minimum amount that they have to pay. But the other provision in here is that the state has to create, it's called an Interested Parties Advisory Group. And this is the group that advises the Medicaid agency on what rates they pay. So as you can imagine, this is a very, very, very important factor in the rule, what rates get set. So there's some requirements here about that. It's not, I'm going to speak them to you. They're not on the slide. The group has to meet, at a minimum of every 2 years. And that's because you don't set rates every year. You set rates in a kind of a cycle. And that it's to set rates for 4 services: personal care, home health aides, homemaker services, and habilitation services. And habilitation is a big umbrella. So the advisory group is to advise the Medicaid agency on the rates set for those 4 services. Secondly, there must be at a minimum on this advisory group direct care worker, beneficiary, authorized representatives of beneficiaries, other parties that are affected by the rates. So there must be people with lived experience, both as a beneficiary and as a worker on the advisory group. As I said, meets every 2 years and makes recommendations. the Medicaid agency, the rules require the Medicaid agency to make certain information available to that advisory group, like the proposed payment rates and data on adequacy and metrics about whether or not people are getting access to care, because it's one thing to provide services, but if you find out half the people don't have access, there must be a rate problem. So that is separate from the MAC and the BAC. That is another advisory group that should certainly have beneficiaries on it, their representatives, and direct care staff. That's kind of a big deal. So the next two are the medical assistance advisory group called the MAC, and the beneficiary advisory group called the BAC. These are two different things. There has always been a requirement to have a medical assistance advisory group. And if you have one in your state, you should have one. If you go, it's a lot of people. A lot of providers, a lot of big corporations, a lot of practitioners, doctors. And the MAC is supposed to cover physical health, behavioral health, long-term care, HCBS, everything. And so the CMS has rethought this whole thing. And they're requiring that a state also have a beneficiary advisory committee, which is made up of people with lived experience and or their family members, to advise on services. And they also say that the big medical assistance advisory committee must be made up of 25% of that big MAC committee must be 25% of it must be people who are members of the beneficiary advisory committee. So yeah, the beneficiary advisory committee is one group, and they must be 25% of the medical assistance advisory committee. So maybe a handful of people from the beneficiary group becomes part of the medical assistance advisory committee. And there are implementation dates. The state has a year to get the MAC up and running. And it has, I think, a year to get the BAC up and running. I want to check my notes here because I made some notes about the beneficiary advisory committee must be separate from the MAC, and it must meet on a regular basis in advance of the MAC meetings, so that the intention is that one feeds information to the other. For both of these groups, the state is obligated to post on its websites bylaws for governance, all the meeting minutes. They must publish publicly their process for recruiting members. They must make of the MAC, the big meeting, they must make that public, open to the public at least twice a year. There are a lot of accessibility requirements to make sure that they can maximize everyone's attendance. There are requirements in the rules for facilitating participation by ensuring that all meetings are accessible and reasonable accommodations are made. So it's not just a requirement to have groups, but requirements to have policies, make public how people are chosen, make the meeting notices public, have a website that posts all of the minutes so that everybody can see everything. And this is really a big deal. I stepped out at 4 o'clock from an all-day meeting with CMS, and right before I stepped out, they reported on something I can report to you. For the MAC and the BAC, CMS is developing a toolkit, and it will have an outline of the sections of the rule and examples of best practices, good practices that states use, and the toolkit will be followed up by a webinar series, 3 webinars that give an overview of the rule and then specifics on the next 2. So they're doing a toolkit, they're doing a webinar series. This is hot off the press. They just announced it today. And then they also are very willing to make themselves available for other training opportunities and information opportunities. So I'm sure that ACL will be publishing all that information so you know a lot about it. And the last thing is that the state's obligated to issue an annual report about from the MAC and the BAC. Okay, let's go to the next one. Next slide. Great. The other thing you should know about and be directly engaged in is this requirement to have a grievance procedure. And as I said, the state has a lot of work to do here. Define grievances, define the protocols for reporting grievances, how they're going to be followed up, what they're going to do with the data. So, you know, don't wait for the MAC and the BAC, because the deadline for those things to be enacted is after the grievance procedure is due. The first thing in the rule is the grievance procedure. So you might want to think about engaging as partners with and support people for your with your Medicaid agency on the design, development, implementation of a grievance procedure. And the next thing on the list I have is website transparency. For all of us, this is great. For any of us out in the real world who want to know what's going on, this is really great. It's a 2027 drop dead date. But one of the many, many things that's supposed to go on the website are the results of all of the HCBS reports that they have to do about states have to report about waiting lists, et cetera. And all of that has to be on the website. So if you don't have a state website now, you will in the future. That will help stakeholder engagement. The last the things I have on here, the big thing is an incident reporting system. So the incident reporting, there's been no requirement for this, although many states have them. And when they fill out the waiver application, they're supposed to describe them. But there are two parts to this. One is, well, let's say three parts. One is requiring states to have it. Two is listing the types of incidents that must be included at a minimum. And three, it must be electronic. So by 2027, the state has to design the system, meaning what's going to be reported, who's obligated to report, who investigates, et cetera. And by 2029, they have to have up and running an electronic management system to support incident management. And you can't really manage incidents and know anything without having good data. So that's something I would hope that stakeholders would also be engaged in, the defining of the incidents, the reporting protocols, et cetera, and making it really, really easy for consumers and families and everybody to report incidents. And the third page. So this is a lot of this page is about what they have to report and put up on the website. So there are requirements by 2027 for the state to report on how they're doing person-centered plans. And there are minimum reporting requirements. I don't have them listed here, but a lot of this has to do with making sure that everybody actually gets a plan every year and it's updated every year. And if it doesn't need to be updating, then people decide it doesn't need, you all decide it doesn't need to be updated, and that it's based on some kind of assessment of what the person needs or wants to live their life in the community. So PCP reporting, and you know, there's a rule in quality management that what gets counted gets done. So states know something's going to be counted in public. You can bet that the annual person-centered plan meetings will be held regularly. This is second one is waiting list reporting. This is really a big deal. The states have to report how they maintain a waiting list, the number of people waiting, and the average amount of time for new people who enroll to wait. And this doesn't say you can't have waiting lists. This doesn't have any timelines for how quickly you have to enroll people. This is all about making this visible to stakeholders, making the state be public about people waiting and how long they're waiting, so that advocacy with your legislature can be based on real data from the state. Access reporting, also very important. What good does it do if you have a person-centered plan with approved services and you don't get them, right? So this is states having to report the average amount of time from when a service is approved to when somebody starts getting it. Homemaker services, home health aid, personal care, and habilitation, the same 4 services. And then the percent of hours for those services that are provided within the last 12 months. So a state has to say in the last 12 months, for these 5,000 people, on average, they were getting this percentage of their authorized hours. That is one way you know whether the rates are adequate, which would inform the rate setting committee. The next 2 are the payment adequacy reporting, all those requirements about how much you're paying people and what percentage of the per diem that you pay the provider is the worker actually getting, and also the required quality measures. States will have to publicly report how they're doing on the quality measures. And lastly, way down the line, 2030 is when the minimum payment requirement for direct care workers kicks in. So as you can see, there are a lot of things in this rule that benefit people who are receiving services, and also a lot of opportunities to be part of committees and or be directly engaged in advising the state on things like how the grievance procedure gets decided to develop, how the incident management system gets developed. So lots of work to do. I like to have the timeline in front of me sometimes because it helps you relax and calm down. It's not all going to happen tomorrow. This is all iterative, and you know that ACL will be there for you every step of the way, explaining, making materials available. And then the last thing I want to say is that NACD and NICL are involved in ACL's grassroots project. We're funding the grassroots project exactly for all of this purpose, to support, provide information, education, guidance, so that you can all engage with your states. Remember, this is a state-operated system and a state-funded and federally funded system. So in this country, we've got 51 states, and each gets to decide how it runs its Medicaid program. Each gets to decide whether it's going to have a Medicaid program, and they all do. But every state is different, and it's designed both to require the states to pay for a portion of it, and that gives the states considerable authority, not 100%, that's what these rules are about, to design that system. But that means you got to be engaged at the state level in that design. And I think I'm done with my presentation.
Thank you so much, Nancy. This is Jessica again from the National Council on Independent Living. I now have the privilege to introduce our panel. Our panel will be moderated today by John Thaler, Executive Director from the Arkansas Governor's Council on Developmental Disabilities, and he will be joined by Nancy Thaler from the Administration on Community Living, Frank Helmer from the Arkansas Medicaid Voice Council and Self-Advocate, and Elizabeth Pittman, Director of the Division of Medical Services, Arkansas's Department of Human Service, and Arkansas's Department of Health and Human Services. Sorry about that. I got a little tongue-tied. And without further ado, I will turn it over to today's panel.
Thank you, Jessica. First, just a shameless plug for Frank. Congratulations on your promotion at Centene. He's a data analyst too, and he just got appointed to the Arkansas State Rehab Council. So Frank's having a week. So good for you, Frank.
Yeah.
So the first question is for you, Frank. How did you find out about the Medicaid Advisory Committee in the first place?
I found it, I think I was scrolling through Facebook one day and just scrolling through my feed, and I saw an ad for it in the I saw an ad about it and I decided to apply for it, just see what came of it.
Fantastic. What made you feel like it was important to do that?
Because I have experience dealing with the Arkansas waiver. I'm under the Arkansas DDS waiver, and so, or CES waiver, whichever one you want to call it, because I have autism, and so I wanted to see if I couldn't lend my voice to help improve Medicaid for others, and I also was using Workers with Disabilities Medicaid, which is another program where it allows you to work and earn an unlimited amount of earned W-2 income and still keep your waiver, because otherwise you lose it after 3 times the SSI rate if your earned income. And of course, you still have to keep your investment income, portfolio income, royalties, rent, stuff like that below the 1 times the SSI rate. So can't have that above about $900 a month, but
Right.
but
Yeah.
that's not really a common situation anyway. But anyway, back to what I was saying, I wanted to raise awareness for that particular thing so that it would help get more people with disabilities into the workforce.
Great. Thank you, Frank. When you think about your time on the Medicaid Voice Council, can you think about a time where your participation made a difference in the state, where maybe you made a suggestion and brought that to DHS?
Yeah, I often hammered on the Workers with Disabilities Medicaid during the meetings, and one time, and at the last meeting I was in, they did a full presentation, and since they were broadcast live for the public, I'm pretty sure that helped the public learn a lot more about it and get more official information on it, and also helped it spell out that it was for the DDS waiver, as well as, because originally the language wasn't really clear if it was just for the AR choices waiver, which was physical disabilities, or if it also included DDS waiver, but we got that straightened out. So the language now says it includes DDS, developmental disabilities, as well.
Very good. Thank you for that, Frank. All right, second question. This one's for you, Elizabeth. How is the state going to ensure that Medicaid beneficiaries are included in important information gathering and decision-making process under the access rule?
Yes, no, great question. And we are going to continue to have a full Medicaid Client Voices Council, just like we have. We actually are developing our Medicaid Advisory Council more fully, rather than our Beneficiary Advisory Council. We're a little backwards. We started getting input from beneficiaries first. So we want to we will automatically have the 25%. We won't have to grow to that. We're going to make that Beneficiary Advisory Council, our Voices Council, part of our overall. And we'll continue to use the points of access, like Frank and I think Mark in our chat have said. The website has been an excellent way to get that out. We actually have had people apply for the committee versus us going out and finding people, because we want people that really want to be there, have some ideas that they want to share with us and the Medicaid leadership team. And doing it that way, we've had a lot of really good beneficiaries serving on our committee, people like Frank, who come with things they're passionate about, things they want us to really work on, and have been able to make some important changes like the ones he mentioned. We've brought our online application to that group so they could help us with making that more streamlined, easier to use. So just really, it's been very effective, and we want to continue to make sure we get all groups represented on that, from parents with children in our Children's Medicaid program to individuals on our waivers, like our community employment supports or DDS waiver, or our physical disability waivers.
That's great. One thing about Arkansas, and this is different from state to state, is that we've got maybe about 5 or 6 main geographic regions, and then the rest of the state is extremely rural. How is DHS addressing that urban-rural divide in recruiting?
Sure. So we've done a few things. One, we do try to pull from different areas of the state. So we do allow for some teleattendance, I guess is the word I'll use. We set up Zooms and allow people to attend via Zoom so that if they're not able to travel for our meetings, they're able to attend anyway. We've also set up stipends, so you get funding to attend our meetings. We provide, I think it's a $100 stipend, and pay beneficiaries to come to those meetings. So if they need childcare, if they're having to take off work, there's still some financial incentive. And we provide lunch when you are there, so you don't even have to pay for meal costs. So we really do try to make it to where there's not a lot of cost associated with coming, travel cost or childcare, anything like that, to try to help with the rural access. And then again, we look at not just programs that you're involved in, but also parts of the state that you are located in. So we get a good rural urban divide and make sure those regions are as well represented as they can be.
Great, thank you. I'm going to ask you this one, Nancy. So when you think about what are some ways, in addition to what we've talked about, how self-advocates can participate in making the Medicaid system work better for them if they're not on a committee? You're mute, Nancy.
I think a couple of ways that one is when people are organized, have an organization, association, just to call up and make an appointment to meet with the Medicaid director or the DD director, whoever is making the decisions. So as a standing association, you can do that. I think the DD councils play an important role here too, because DD councils can help to arrange meetings with people in positions of authority and power. I would say that it's good to know, as self-advocates, it's good for you to know and meet people in the executive branch under the governor, like the secretaries and the deputy secretaries, and know them personally by name. You don't have to have a lot of meetings, but once they know you and you've said something important, they won't forget you. But at the same time, try to make relationships with members of your legislature, your General Assembly, your local representative of your senator. And you always want to be making sure that people both elected in the General Assembly and in the executive branch both know who you are and what is important to you. And so I think those are two ways you can influence by being present and letting people know what's important to you. You can influence policies and laws that are made.
Right. Thank you, Nancy. Last question, I'm going to ask this to each one of you, and I'm going to start with you, Frank. What do you think are some ways that self-advocates can stay up to date on the work that their state is doing to improve home and community-based services under the access rule?
I keep up to date by following the disability rights and the Governor's Council on Disabilities and other interested organizations. I follow them on social media, and I list when something like that pops into my feed, I look at it. So following interested organizations on social media.
Okay, so social media is a really good channel for you to keep track of things.
Mm-hmm.
Okay, great. Elizabeth, what about you? What do you think?
I definitely echo social media. We have social media pages, and we also follow some of the groups that Frank just mentioned. We also have an advocacy group called Medicaid Saves Lives here in Arkansas, and they keep up pretty well. If you want to follow what Arkansas Medicaid is doing directly, we have a web page where we put all of our public comment notices of public comment for any rule we're putting out. And if you reach out to our Office of Promulgation on that website, you can get added to a list of interested parties. So here in Arkansas, if you ask, we have to send you notice of any rules that we put out. So you can ask for that, and then we have to tell you what we've got going on. And then we also work with some of the groups that you just mentioned, Frank, to do Facebook Lives or Zooms or things of that nature. If you hear about those, attend them, send us questions. And I'd also echo what Nancy said. We like to meet with our councils, our advocacy groups, and our beneficiaries. So reach out to the Medicaid director, myself, to the DD director, And we'd love to hear what you are, what your questions are, what your concerns are. We want to make sure the programs are working as well as they can be, and we know there are always can be improvements. So want to hear about it.
Thank you, Elizabeth. And Nancy, I'll let you close that question out. What do you think self-advocates can do to stay up to date on the work their states are doing with all this? Oh, you're mute.
Yeah, I'm sorry.
No,
said,
you're okay.
You know, that's a really good question because it's really hard to do. These systems are complex and they're big. And so I would say a couple things. Not every single person can do everything and know everything. But if you have an organization like your self-advocacy organization, the DD Council, Nickel, where there are paid staff, your P&A, where there are paid staff whose job it is to know what's going on. And if you stay engaged with them in some way, go to meetings, be on their listservs, they will be able to screen out all the noise and highlight the things like I did today that mattered to self-advocates the most. And ACL, who I work for, are very supportive of the DD councils and the P&As and Nickel and the SIL, all the SILs, so that they can help individual stakeholders, people with disabilities, people who are older and their family members have a voice. So we're counting on them to organize meetings, to keep you informed. But good for you, Frank, for cruising the social media and finding stuff out for yourself. You are one of the go-to people. So, you know, when you're together with your self-advocacy groups, you're one of the people who will let everybody else know what they need to know.
Great. Well, thank you to my panel for asking our questions. And I know we had some questions within the Q&A. Mary Kate, do you want to run through those for us?
I've got it, John. Hi,
Thank you,
everyone.
Jessica.
It's Jessica from the National Council on Independent Living again. And now we're going to run through some Q&A in the Q&A box. So our first question is, how does the managed care plan rating system, or how is the managed care plan rating system going to work in states where there is only one managed care entity?
Where is that? Because there is an obligation for choice. There's supposed to be always more than one, at least two. But
This is Erin, and that question came from Kristen Murphy from Vermont.
Oh, so that's from I'm going to get into the policy weeds a little bit. So in many ways, Vermont is not really managed care. Vermont and Rhode Island have approval from the federal government to manage globally, but they don't bid out and contract with managed care companies. So if you were to go into another state, Massachusetts, for instance, their physical health, they bid out, and big companies, national companies like Centene and Amerigroup and Aetna bid on these contracts for physical health. So Vermont is off the grid in a way, in a lot of ways, but particularly in managed care. But because it's not really managed care that's privatized to private companies. So by the way, in Vermont, everybody's supposed to have choice. So I think in Vermont, what you have are regions that sort of manage everything. And I believe your state and your DD council is very active in conversations with CMS about making sure at least you have choice of case management and that that's conflict free.
Thank you, Nancy. Our next question is from Sheldon. It is not true that every state has capitated managed care plans running their Medicaid programs. 10 or so states, including Connecticut, do not have them. Do any of the requirements for secret shopper surveys and enrollee experience surveys apply in FFS and managed care FFS states? So FFS, I believe, is fee for service.
Right. My tentative answer to you is I don't think so. But as I said, this rule is very detailed. So don't take my answer to the bank, but I don't think so.
Okay. And then should DD councils be on the MAC and Medicaid Beneficiary Advisory Committee?
So if you look at who should be, it includes parties that are interested. If you mean, should the council have a seat as the council? Probably not. Would a person that's on the council be a good candidate? Yes.
Okay. And then can DD council members be members of the Beneficiary Advisory Committee?
Yes, yes.
And then does the rule stipulate that the Beneficiary Advisory Committee and the Medicaid Beneficiary Advisory Committee must have people with intellectual and developmental disabilities?
No, there's no specificity about the life condition or situations of the beneficiary. So what the rule says is anybody who is who benefits from Medicaid services. And remember, that's a lot of people. That's people with and without disabilities. It includes physical health, mental health, children's services. So the pool of people that can be drawn from is very, very big.
And then this one, I'm almost scared to hear the answer, but what adverse effect will the Supreme Court's overruling of Chevron have on the HCBS rules, if any?
Well, I wish you heard Allison Barkoff today, because she made some comments about this, that everybody's jumping off the cliff a little too soon. That the decision, this Chevron decision, I'm just sort of going to paraphrase what she said. It's been 10 years since someone has had to use the Chevron decision to defend a rule that over the last, I would say, decade, I've witnessed this myself, and you'll see it in this access rule. You will see that the federal agencies have been more and more publishing rules and the narratives, the preambles, to explain how the rule is authorized in the statute. So in many ways, the federal agencies in writing rules have already been inoculating them from that challenge. That's not to say we shouldn't be concerned. It's not to say it was a good decision, but we're not going to be losing all the rules tomorrow. All the rules will be intact.
Thank you, Nancy. And then the last question in the Q&A box is, can advocacy groups or entities serve on the Beneficiary Advisory Council, or is it only individuals? Does the rule require disability representation?
Hello, Lisa Tesler. She's from my Disability Council in Pennsylvania. The rule does not reference any kind of organizations. It really is about beneficiaries, but not only. It's beneficiaries, they're authorized advocates, people interested in. So is the executive director of the DD Council a likely candidate for the committees? Sure, absolutely. Not as a beneficiary, unless they're actually getting services, or they are a legal representative of somebody getting services, but in that broader category of interested parties, for sure. And I would say that being on the committee is one thing, but attending the public meetings is another. In the state that I come from, in Pennsylvania, when the MAC meets, the room's loaded with people from all over. The public comes to those meetings.
Yeah, and I would not be an independent living representative if I didn't also flag that this is an excellent space for our independent living centers to get involved in their systems advocacy and really work with the DD councils, and for some really good cross collaboration here on ensuring the disability voice within these councils. So had to give that little plug. Couldn't not. So and without, I guess I think I'm turning it back over to John.
Wow, with 5 minutes to spare. Okay, well, then in the name of keeping things on track, at the beginning of this, Erin said that she would offer a call to action. And so I really have two parts to that. The first thing is, Nancy stated at the beginning of this is a big rule. So I would challenge everybody on this call, take the time to read it, to study it, and to understand it, and definitely watch out for that toolkit when that comes out, because I think that will make understanding the execution of this rule a lot easier. And then I'll end with what Aaron said, which was, this is an opportunity to take everything that you're learning and go back to your own state and make home and community-based services work for you in the way that works best for you. And so with that, I want to thank everybody for taking the time to be part of this call. I want to thank all of our panelists for all of the hard work and all of the semi-constant email streams that were going on between all of us. I really appreciate that, particularly last week on a holiday week. It was a lot to make happen. So I appreciate everybody for your time, and go back and make this work for you. Have a great day.